Good morning, everyone. I am Jessie Whittish with Kentucky Youth Advocates. Thank you to all of us for joining us for what I believe is our 24th Advocate Virtual Forum. We'll celebrate a special milestone next week. So just a reminder that we're recording today's forum to share later as both a video and as a podcast. So we ask that you stay muted, but if you want to drop in questions or comments in the chat feature, please do. Panelists, if you want to answer those, you can. If not, we will answer those. We'll do a follow-up to answer those. So we are so excited about today's guests, today's panelists, to talk about the TEN-4 Bruising Rule and child abuse prevention in especially our youngest kids. To kick us off, I'm going to turn it over to Terry Brooks.
Hey, thanks, Jessie. I think we've started now at least 23 times by saying thanks for joining us, whether this is the first time that you've been here or the 24th, and we've got some 24 people here, so that's really great. Before we start, I want to take just 30 seconds and issue the same call that we've issued for the last 2 or 3 weeks. It up a little bit. We want to emphasize now is the time to also call Washington. All of you have a representative, and all of you have 2 senators. Anyone who does not think that conversations around the Supreme Court vacancy puts COVID relief in jeopardy is delusional. So if you're on this call and your sector is early childhood, call. If you're on this conversation and your beat is K-12, call. If it's child welfare or public health or juvenile justice, call. And the message is really simple. And that is that we have to honor, I think we have to honor the debate and discussion going on around that Supreme Court vacancy. We all understand the political hue of that discussion, but that doesn't have anything to do with the COVID relief packages that are being discussed, especially when it comes to kids and families. So make your voice heard, whether that's Democrat John Yarmuth or the Republican members, the rest of the delegation. Leader McConnell, as we all know, is critical to this, as well as Senator Paul. So I don't think we would be authentic in our mission as a group if we didn't take just 30 seconds and say, don't divorce your voice from Washington, because it's so critical. And the next couple of weeks are going to determine whether this can happen this fall or whether we're waiting until after the election. So there is a time urgency to that I want you to hear. We will continue to post resources, not tell you what to say, but resources on our website. And we would encourage you to look at that, link to that, and take action. So today's topic is really built around the TEN-4 day that Kosair Charities and so many partners are getting ready to launch. I feel like many of you on the call should be teaching me, so I don't want to bury the lead here. But I do just want to emphasize what we all know, that child abuse is complex. The causal factors are complicated. Anyone who does not think that the days in which we're living are not creating unprecedented levels of trauma for parents and caregivers and kids are being naive. That trauma is life in general. It's economic stress. It's pandemic stress. In many localities, it deals with civil unrest and the intended results of that. So we know that if we believe that child abuse and trauma are tied together, there has never been a more serious moment to think about taking action. And that's what TEN-4 is about. It's an important issue, but it's also a canary in the coal mine moment where we're raising the broader issue to many people. I do want to make sure that we know that our focus today is going to tend to be on little kids. That doesn't mean that young people and teenagers are not experiencing serious trauma and stress. But it is important for us to know that, and Dr. Currie, I'm sure, can speak to this at a much deeper level, but Kentucky's Child Fatality and Review Panel, the last time they looked at numbers, 75% of the cases dealt with children 4 and younger. So within the sector of Kentucky, if we're talking about abuse, we're really talking about 2 and 3-year-olds, not 12 and 16-year-olds. I find that as a grandfather, just can't wrap my head or heart around that phenomenon, but it is a phenomenon that we need to address and deal with. So we welcome you today. This is such an important topic and such a broad topic that, again, we hope you really embrace the TEN-4 notion, but you see the TEN-4 notion as part of a much bigger picture. There is no one who frames the big picture issue better than Keith Inman. He represents Kosair Charities. And if there is a stick that steers the drink in Kentucky when it comes to combating abuse and neglect, it's Kosair Charities. So here's Big Stick, Keith Inman.
I've been called a lot of things, Terry, but that might be one of the nicest ones. I don't know, but thank you, and thanks to each of you all who are on the call. You're very, very inspirational to me, and you're what motivates me every day. And I really appreciate that. I really appreciate that. And as Terry alluded, anytime there's 2 or more people, or really 1 or more people, I'm talking about child abuse. I just think that is even with the crazy world we're in, I think this is the #1 public health issue that we have to deal with. And obviously, by definition of the times, all of our children, all of our kiddos are special needs kids right now. So in the stress and environment, it's crazy. But this didn't seem that long ago. It was 2013, and Terry and I were in a small room at Kosair Charities. I had not moved to Kosair at that time. I was representing the University of Louisville. And Terry and I were in a room where Dr. Currie and Dr. Jerry Rabelais laid some just horrible, horrible stats on us. And Kosair Charities felt it had to do something. So we committed to creating at the time, the Face It movement, so in 2013, with a broad goal, and we're not afraid of big goals. Kosair has been around for 97 years, and we made it through the polio wars and a lot of ugly things that affected kids, but this might be the ugliest. But we've taken on a big goal, and we stated in 2013 we wanted to end child abuse by 2023, which is our 100th birthday. We have a lot of work to do. We have a lot of work to do. And that's why each of you are heroes and inspirational, because you take it on every day. And this is something that's just near and dear to my heart. We started with a few partners that day, Terry, and we've grown to over 100, and we're statewide. We're focused in every nook and cranny of this state. And again, appreciate what you're doing. We're really focused in 3 areas. Face It's focused in 3 areas, and that's promoting best practices, obviously, building awareness, and advocating for policy changes. And we've got a great track record. We've been able to accomplish a lot. But guess what? We're still #1. We're still #1, and it's time to change that. Living in Louisville, we've got Indiana across the street, and they're always trying to, tell us how much better they are than us, but they're #2. So they're not much better. So we've got a lot of work to do. And, today's forum is going to address, all three of those levers as we look to recognizing abuse, but preventing abuse. We have got to prevent abuse. And in Kentucky, it's cultural. Let's just face it, it's cultural. We have to deal with it. And so today we're going to we're going to talk about it. And in honor of, the TEN-4 Bruising Rule, which, even I can understand that, which is great. We need to make it simple, So, we're going to celebrate it on October 4th, TEN-4 on TEN-4, and, that's neat. But we're going to be hosting a series of virtual seminars, which are free. And we all like free. So, it's going to be to professionals, volunteers, parents, anyone who is interested in this. So please help us promote it. And I think Jesse's going to be sending out some links, to these things that are going to be, and it's going to be from September 30th through October 8th. So again, promote it. Hopefully we'll have some proclamations from, the governor, mayors of Louisville and Lexington, and hopefully mayors across the Commonwealth will recognize this very, very important day and this very important rule. So, let's hope there's a lot of surprises out there, and let's pay attention to social media as we go through this. But again, thank you for what you do every day. Thank you for pushing Kosair Charities to do more. We will be with you, and we're not going to give up in 2023. I have a feeling we're still going to have work to do. So let's just stay focused. As Shannon said, we all like big goals, so let's get after it. But again, thank you for what you do, and I'm going to turn it back to Shannon Moody now.
Thank you, Keith. I really appreciate the call to action, and I do love big goals. And I think we've got one of my big goals was to have one of the people that developed the TEN-4 Bruising Rule engaged in TEN-4 awareness in Kentucky, and we've hit that goal, so I'm really excited about that. But I wanted to say that what I think that we need to keep in mind as we start this conversation and as we get into what strategies we can uphold is that, we need to remember that a majority of people don't wake up thinking about abusing their kid. They wake up overwhelmed, without appropriate tools to address their emotions, and are not able to access or not accessing supportive services. So just keeping that in mind, and that is one of the reasons why we have Pam Darnall with Family and Children's Place, and Lynn Hulsey, who, Pam Darnall is the president of Family and Children's Place. Lynn Hulsey is the director of programs at Family Enrichment Center. We also have Dr. Melissa Currie, who is the medical director and chief of the Kosair Charities Division of Pediatric Forensic Medicine at University of Louisville. She's going to have to correct that title for me. And then Dr. Mary Clyde Pierce, who is a professor of emergency medicine, pediatrics, and preventive medicine at the Northwestern University Feinberg School of Medicine. And Dr. Clyde Pierce was one of the originators of the TEN-4 Rule. So any additions to those introductions before we jump into questions? Okay. All right, awesome. So this is for Dr. Clyde Pierce to begin with. Could you tell us just a little bit about the development of the TEN-4 Bruising Rule?
Yeah, I would love to. Can everybody hear me okay? Can you hear me okay? Okay. Yeah, so I'm Mary Clyde Pierce. I'm a pediatric emergency medicine physician. And several years ago, a handful of years ago, I was also the head of a child abuse team in Pittsburgh. And so when I had that dual job, I'd work in the ER, then I'd work on my child abuse team. And I noticed that the injuries, especially the skin injuries, were really, really different when these accidental injuries versus these abuse injuries, especially around ear bruising or neck bruising or torso. Different types of bruises, they were just different. And it really got me. And I noticed that people just kind of didn't pay attention to bruises because they didn't think they were serious. And so they equated the risk to the child to be the severity of the injury. So if the injury wasn't severe, they thought the risk wasn't severe. And that was a real big misstep that I kept seeing that was leading to children actually then having a subsequent fatality. So I kind of became obsessed. And I started trying to do a project. I moved to Louisville right after that because of a great job opportunity. and a great group of people there at the University of Louisville and at Kosair. And I really wanted to do a head-to-head study of accident versus abuse. And I finally convinced a team of nurses to help me. That was really the nursing at Kosair that just opened this wide open for me, because they do such a careful skin exam on every patient up in the intensive care unit. So we started collecting data, and we did a study where we actually looked at abuse versus accidental bruising, and then worked with a great biostatistician who's still at University of Louisville, Doug Lorenz, and Kim Kosair is the bioengineer that was helping me. And then the nurses, Justy O'Flynn and Sarah Aldridge, who's now an APN as well. And so it was just great. This is team of we were kind of like a team of bad news bears in a way, that just really were tackling this and refusing to let go. And we collected this data on all these children, and we put it into a modeling, and we actually I was really shocked with the results, because it was so different. I felt anecdotally that it was different, but now we had the evidence that bruises from being physically assaulted cause very different injuries than did just having fun or having even a big trauma. Even car crashes were producing these same kind of bruises. So we wanted to make something practical, because I'm a very practical person, because of my emergency medicine job. You need something that makes sense, something that's memorable, and something that can actually really kind of stick. And so we had this bruising constellation that were actually quite different. We modeled it. And so we came up with the TEN-4 rule, which means if you had bruises to the torso, which is your chest, abdomen, back, or buttocks, if you had bruising to your ear or to your neck, or if you had any bruising anywhere for infants that were under 4 months of age, anywhere, it was actually strongly predictive of abuse. So that was actually quite exciting to see this difference occur. The person that came up with the TEN-4, to call it TEN-4, I came up with ENT4, which was ridiculous because it's already something else. So the biostatistician's wife, like everybody, just once you start getting involved in this, like you were saying, Keith, it becomes quite, a lot of us become very impassioned about this. And so we came up with TEN-4, and it's been it's made a big difference, I think, in people being able to remember and recognize these predictive regions. I have people call me from all over the world and contact me and say that they identified a child that was being abused that they would have completely missed if they hadn't recognized a simple little finding on the ear or the neck or something like that. And it's exciting because people are using it and it's making a difference in lives. And I loved the intro, Shannon, where you talked about how we're trying to find people that are distressed. Distressed families hurt children. Evil people, it's uncommon for people to be evil. Most people are not Charles Mansons. Most people are just regular people that are distressed. And as a medical community, speaking from my own perspective, as a medical community, we should be embracing these families. These are the families that need us the most. And so I'm excited that if we have these early signs, just like we had an early sign of cancer, like a blast cell, we wouldn't push those families away. We would actually embrace those families. So if we have these early signs that something is going wrong, it's a great opportunity to prevent the next thing that's going to happen. Because unfortunately, abuse tends to be an escalating type of trauma rather than just a one and done. And so that's why I'm excited about this, of thinking this is an early warning sign or a canary in the coal mine sign that we need to do something, and do something compassionately now,
Yeah. And I so appreciate the practicality of that. And Jesse had put up the TEN-4 visual that we created. We wanted something that was a little more accessible, and hopefully still do the rule justice. But
I love it. Yeah.
Thank you. Yeah. So thinking about that, that embracing of families, and thinking about the stress that folks are experiencing, why is the emphasis on what to recognize in young kids so important? Mm-hmm. And, what concerns do you have in light of COVID? And I think, Dr. Currie, Mary Clyde Pierce.
Yeah.
Go ahead, Dr. Pierce.
No, I was just going to say that the reason our rule, I forgot to mention that the rule focused on the younger children for two reasons. One is that I'm very passionate about this group because they're unable, from my ER experience, they're not able to tell you that something is wrong. Or I found over and over again, they were terrified. Even if they're old enough to speak, they were terrified to say something. I watched parents manipulate the child right there in front of me because the child was so terrified. And so I really wanted to develop a tool that could help our healthcare providers or social workers or whomever is interacting with that child. I wanted to develop a tool that we could use to interpret the data without a child having to be able to tell us. Often they're too young as well. And then what is it, like 2/3 of the deaths, Melissa Currie, Dr. Currie can correct me if I'm wrong, but 2/3 of the deaths occur before that child ever reaches their 4th birthday. and half the deaths almost before the first birthday. So we really have to have something that doesn't depend on somebody telling me something, you know.
So we know that abusive head trauma is the most dangerous and deadly form of child maltreatment. Abusive head trauma causes the most disability if the child is lucky enough to survive, and it has the highest rates of death. And that is really what part of what we're trying to prevent by picking up on these early warning signs. And the peak age for abusive head trauma is around 4 to 5 months of age, but most of the victims are less than a year. So that's why we focus so much on the babies, is trying to find out what are the early warning signs so that we can intervene before it escalates. That's one of the patterns that we know with child maltreatment, is that it's very similar to domestic violence in that it tends to escalate over time. More than half of our victims of abusive head trauma, at least in our program, have evidence of prior injury. So it is very, very rare for a child to be seriously injured or killed the first time they're abused, which means we have an opportunity. We have an opportunity to notice these early warning signs and intervene. And it's just such a powerful tool because it's so accessible. It's an honor to, you know, have the opportunity to work with Dr. Pierce and, you know, to do these trainings and help spread the awareness.
Thank you. Yeah. So we know obviously that intervention, and when the doctors or nurses are seeing the kids, at that point, abuse has maybe already occurred. So obviously the recognition of those early warning signs is critical. We also know that prevention is the ideal, right? We want to get to the point where we're not having to worry about abuse at all to begin with. And I'm just wondering, what are some of the primary prevention strategies, whether it's Pam with hands, or some of the other services that you provide, or Lynn, or even for our docs who address people regularly about the primary prevention? What do those strategies look like? What do you tell people?
So Shannon, I'll be glad to jump in. This is Pam with Family and Children's Place, and thank you all for inviting me to be a part of this awesome panel today. I'm honored to be in the presence of you guys, so thank you so much. Family and Children's Place, all of our work is about preventing child abuse and family violence, and then stopping it when it does happen, and helping those who are hurt to heal and get the services they need. But really, Kentucky is so fortunate because we have an amazing prevention program right here in Kentucky. It's statewide, it already has a pay source, and it is called HANDS, like your hand. And this is a high quality evidence base. There's research to show that it's effective home visiting program for new parents. And it really does speak exactly to what Dr. Pierce was saying. It really does serve these distressed families. And I was thinking about Dr. Pierce and some of the language that she used. And I believe that when we work with those families who have vulnerabilities or are distressed with supports like in-home high-quality services, that really equals the support that families need, which will lead us to preventing this type of injury from ever happening. And so these HANDS services, as I said, are in every county of our state. I will share a small plug that what is now HANDS actually originated at our agency in the early 90s, when there was a huge increase of child abuse and neglect. And we went to our health department, great partnership, did a pilot, which turned into HANDS. And so we just really know that prevention is the key. And even in HANDS now, there's some very specific work that we do with families around shaken baby syndrome. And that information and that work with them begins in the first few visits that we have with every family. And then even later in the pregnancy and right after that baby's birth. So we really know and live it every day that prevention is the key.
I'd like to add one thing about, thank you, Pam, for those comments. And I really echo the powerful nature of the HANDS program. And we in the medical profession should be doing a much better job, quite frankly, of getting families connected with HANDS just even while mom is still expecting. That is the ideal time for that referral to take place. But if not within the first 3 months of life, we can't refer after 90 days. So it's really important to make that referral early. But one thing I wanted to add as far as prevention, I think applies to all of us, regardless of our role or our profession. And that's helping families understand realistic expectations for their child for their given age. Unrealistic expectations is one of the most common threads that I see going through the cases that we evaluate on our team. You know, we have, children being physically abused because they had a potty training accident and the potty training was started at 14 months of age. Child isn't neurologically ready to do that. And that's just one example, but there are multiple examples. The other prevention area is infant crying and helping families understand that infants do cry. They cry a lot and they cry for a lot of different reasons. But one of the things that we see with perpetrators is the perception that the infant's crying means that the infant doesn't like them. Mm-hmm. And that is a really common perception among perpetrators that we obtain medical histories from on the kids that present to the hospital. So to the degree that we can all help families have realistic expectations and to understand that infants cry a lot, it is okay to put the baby down and take a break. Crying doesn't hurt a baby, but continuing to hold them while your frustration level is increasing could be potentially deadly.
Mm-hmm. That's great.
Lynn, you're muted.
Sorry.
It's okay.
If I could just chime in for a minute, at Family Enrichment Center, we do say all the time that I don't think people have children intending to hurt them. I think they just are not prepared, and we find day in and day out that they parent how they were parented. So, if you had a really bad example, odds are you might be a bad example too. So we don't do hands, but we have a program we call Little Learners, and which actually the curriculum we use is parents as teachers. And so what we've done with our Little Learners program is we've partnered with school systems because we find that funding is really available for kindergarten readiness. So we've been able to tap into that aspect, but it achieves our mission of child abuse prevention because we can serve families from pregnancy through kindergarten entry. And the thing about the program is that we want them in there from pregnancy to kindergarten, and we partner with HANDS. When they leave HANDS, HANDS can refer to us, or if they miss the cutoff for HANDS, then they can come to us. But we are serving 6 of our 10 counties with this program, and we find that parents, it's just like Dr. Currie says, they don't have an understanding of, sorry, my husband burned the bacon. They don't have an understanding of what a child should be doing at certain times. So I think when the premise for our program is that a child's parent is their first and best teacher. So we do everything we can to support them. We do constant screenings to make sure they understand that, they're not ready at 14 months to potty train. But at 4, before they go to school, they should be able to at least spell their name. So it makes this child a real person to them. We see all the time, it's almost like there's like some kind of magical age where a kid has feelings. There's such a disconnect sometimes we see with empathy, that, oh, well, my child does feel that. I had a mom in parenting class once, and this was an epiphany to me. She said in parenting class, in the beginning, we were talking about spanking, and we, of course, are not proponents of that. So she's like, are you gonna harp on us about spanking? I'm like, no, I'm just gonna provide some information. Then you'll have to choose what you want to do. And at the very last class, she came up and she said, you know, I'm not ever gonna hit my kids again. And I was like, well, okay, that's good. That's what we wanted you to say. And but her reasoning was that she never realized that when she hit her children, 2 little boys, that when she hit them, they felt like she felt when her husband hit her. It was like all of a sudden she had this connect of that they did have feelings and that they had a response just like she did. So we believe in early intervention is absolutely the key. So
yeah, love it. I love the direction of this conversation. And so I think so often people get so focused on injuries that they think of it as we in the medical community at least also can objectify rather than humanize what is actually going on. And that's the absolute opposite of what needs to happen. So it's so exciting to hear the stories and the approaches that y'all are taking there in Kentucky. I love it, you know?
Yeah, thank you. And you know, I think that humanizing piece is actually a good segue into the next question that I have, which is around systemic trauma and systemic racism. I think a lot of times what we see in situations where people are coming into our hospital or into our clinic, we're not always recognizing bias, and we're not always recognizing how to make sure that we're attending to that bias. But I think that we can't talk about child welfare without talking about systemic racism and the trauma of racism. And I'm wondering if folks have thoughts on how we can advance equity within child abuse prevention and intervention. Like, what do you think that looks like? I know we've been talking about really practical, but if maybe there's some also theoretical components to throw in there, please do. But what are your thoughts on that?
I'll start by speaking to that because this is an issue that I'm passionate about. I think one of the first steps all of us should take is to look within ourselves and use the tools available to recognize our own implicit biases. We all have them. We may not think we have them, but we have them. Harvard has a website with some wonderful tools to assess your own intrinsic or implicit biases. And we can't work to overcome our biases unless we know what they are. So that's the first step, is to identify what our biases are. And then we work consciously and methodically to overcome those. So for example, if I find that I have a bias against skinny people, and I'm working with a family they're all skinny, and you know, I'm feeling, you know, concerned about the child, or I'm thinking about abuse or whatever. I need to stop and check myself and say, wait a minute, if this was a normal weight or an overweight family, would I be having the same reaction? And that's just a simple tool to help us reframe situations to make sure our biases aren't getting in the way. And I'll admit, I've used this tool and I've caught myself. You know, saying, if this was a family without all of these risk factors, would I be reacting the same way? And that can be tricky because risk factors do matter. But I think identifying our own implicit biases is the first thing. And I think the second thing is simply acknowledging the reality of systemic racism. A lot of folks still don't believe that it's there, or don't understand how it's there. And I think it's incumbent upon ourselves to educate ourselves about that. And it's really important. I'm so grateful that this is part of the conversation today, but that it's becoming part of our national conversation. And hopefully the deaths of George Floyd and Breonna Taylor and the others, Ahmaud Arbery, won't be completely in vain if we can learn and acknowledge systemic racism and start taking steps in the right direction to address it.
That's great. One of the things too is that making ourselves look more carefully when a person is Black or Hispanic. Those are the two groups we found that we have the biggest problem with when we actually are making decisions that look like they're the same on the surface, but when you look more carefully, they're not. And what we found is that sometimes people interpret risk factors differently based on the skin color. So they go in already with different ears. So it's almost like what we were talking about, the attributions of children. People are attributing things incorrectly, and they don't even realize it because it's based on something that they've already seen. We had people assuming that because children that were coming to the ER that were Black and they were coming in at later evenings, there was this assumption that was already made that they were probably from a poor family or they were from like a worse part of the Chicago area, which was interesting to just hear people say that out loud and then to ask them, why did you think that? And then to watch the onion peel back on why we actually even start with that premise, and then it actually sets this whole family up for actually being treated differently. And that's that racism that's almost invisible. It's invisible to us, but it's not invisible to the families. And so that's why it's so critical for us to actually just like look at this ugly. It's ugly, but just because it's ugly doesn't mean we don't grab it and embrace it and figure out how to change it, you know. But I agree. It's like it starts with us just being willing to look at a very ugly part of it and to like say, no, this isn't going to be it. This isn't going to be it, you know.
Yeah. There is actually research, and Dr. Pierce just alluded to some of it, but there is research that even just with abusive head trauma alone, that we are actually more likely to miss the diagnosis if it's a white family. And that's because we have a tendency to give the benefit of the doubt to people we perceive to be like us, and we tend to be more suspicious of people we perceive to be not like us. And that is an enormous problem.
We do see that often too, that people make assumptions about, well, if they have money, they don't hurt their kids. The only people that hurt kids are poor people, or, you know, we are full of assumptions about all kinds of things that really do direct how we relate to people, for sure.
I'll just add one more thing real quick, and that is that within our Department of Pediatrics at the University of Louisville, we're starting to screen more often for not just all adverse childhood experiences, but specifically screen for racism and to ask patients how that is affecting their lives and ask their parents. I am so proud that the University of Louisville actually changed their overall mission statement this year with our new president, Neeli Bendapudi, and she has actually put in that we are going to be a leading anti-racist university. And it's not just words, she's following through. There has been a lot of programming and a lot of policy change, and I know there's much more to come. So I'm proud to be associated with the University of Louisville because I think they're being a leader at this point in addressing this.
It's fascinating. That's amazing. That's fantastic.
And I'll just add as well, you know, our work with families, it's really important, and I'm just sort of reiterating what many of you have said, especially you, Lynn. I loved what you said about, you know, parents know their kids best and they're their best teacher, but it really is on us as white people, as we're working with Black people and people of other races, it is on us to learn their culture. You know, we don't want to go in and they don't need us to rescue them. We are there to support them in their learning. And they're working with their own children, and it is on us to understand their culture and whenever possible to speak the languages that they speak if they are non-English speaking. So in addition to understanding our own personal biases, we need to, as human service providers, take the next step and learn those cultural differences and appreciate and value and celebrate those when we're with those families.
I love it. That's fantastic. One of the things
I noticed in the chat that there is a social worker who works in a medical setting, and he or she says that she sees white privilege rear its head all the time, particularly by doctors and residents. And I can't agree more. I think the term white privilege is one that hasn't come up, but it goes hand in hand with systemic racism and acknowledging, the freedoms that those of us who are white have that others may not. I can shop in a department store and not worry about being followed by a security guard. I can name my child anything I want to name my child without worrying that they're going to be discriminated against later in life because of maybe the ethnic or cultural nature of their name. And that white privilege really permeates our society. And again, acknowledging it, that it's there, is the first step.
Yeah. Mm-hmm.
I think too, I was born and raised in Eastern Kentucky. And so my family's all there, and I hear a lot of conversation around white privilege. There's something about the word privilege that sticks with me, is I don't think that everybody understands that word, because what I hear from home, I hear people say, well, I worked for everything I've got. I'm not privileged. So I think sometimes the words we use matter. And I think maybe sometimes that kind of stymies the process of helping people understand the whole big picture, because of not understanding really what that word truly means.
Mm-hmm.
That's an excellent point.
Yeah, absolutely. Framing, language, how we talk about things, the practicality, making things accessible. Going back to the bruising rule too, the reason that is accessible is because they were very intentional about the language use and the way that it was conceptualized. So thinking about how we connect with folks to make sure that we're understanding them and showing humility based on what their culture looks like or what they're experiencing is incredibly important. And we're talking about kind of big picture systemic changes that we know need to occur. And then I think we're identifying ways in which those changes happen. I'm wondering, thinking about policy and policy changes, knowing, that this is a community public health issue, what are some of the policy priorities, particularly related to the budget, that we need to better help address these issues? What does that look like for folks? What do we think we need?
You've stumped me, Shannon.
Okay.
If you have suggestions as a policy wonk, as I know you are,
Yeah.
I'm happy to try to speak to those. But, I'll say this. I'll say that any policy that requires us to use an objective algorithm rather than allowing us to make subjective decisions based on our perceptions of people is a good thing. That's one of the beautiful things about the TEN-4 Bruising Rule, is it helps take that subjectivity out of it. So that's my comment so far.
Yep.
One of the other things that I think we are anticipating in this coming legislative session too is there's another budget to be determined. And sometimes policymakers have a hard time prioritizing, what needs to be put in the budget. And are there any thoughts or ideas on what types of strategies or policies or programs that we know are effective in child abuse prevention. I know we've talked about HANDS and we've talked about Family Enrichment Center. Are there other things that come to mind that we need to make sure are being prioritized, especially in light of the stress and potential economic impacts that folks are feeling?
I think
Substance abuse treatment and access to it, child care assistance, for families that need it, universal health care. I'll put a plug in for that, especially for children, but I think parents need to be healthy too. Those are the ones that come to mind. And I will say too, this isn't necessarily General Assembly policy, but as far as institutional policies, having recruiting policies that prioritize underrepresented minorities. You know, when we admit our students, when we hire our staff, and when we hire our faculty, using U of L as an example. And I'm sorry, Dr. Pierce, I think I spoke on top of you.
No, that's okay. I was going to say, you know, like the child care, I think that if I could change two things with a twick of my nose or whatever, I would actually have child care be something that mothers or fathers can actually have access to, and easy and safe access to, because that paper that we published on the caregiver, that what was it, they were 100 times more likely to be, the child was actually physically abused and the boyfriend was with the watching the child even for a second, the likelihood of abuse was wildly higher, like the odds were increased by 100, you know. So just changing one thing, even though it would be kind of expensive, but in truth, that is the cost would be it would be such a cost savings to be able to have healthy, safe childcare for women and fathers alike, you know, whoever the caregiver is, to be able to have that safe kind of childcare. Then the second thing that I'm passionate about is that if we don't figure out how to have education, even early childhood education to be the same across everyone, whether you have public or private, if we don't change that, we're never going to be the country that we could be. So everybody in the United States, we should be so proud of every single child's education that they receive. And that, I think those two things would change the face of this nation and abuse going forward.
Couldn't agree more.
In Kentucky, one of the reasons I love working with my Kentucky colleagues is that everybody else, I collaborate with people all over the country, and everybody's just mostly talk. But Kentuckians are do. You just always are action people, and everybody else is talking about things when you've already implemented things like 3 years ago, and I love it, you know, so.
I love that. Yeah, thank you. Yeah, for sure. And speaking of action, what can advocates on this forum and the organizations that they work for or with do to keep kids safe, whether that's big picture or you know, really more narrow tasks or actions? From everyone, what is at least one thing that advocates on this forum can do to keep kids safe?
Well, I seem to always talk first, so I'll do it again. You know, my list is really long, but I think keeping child safety front of mind is the first step. You know, remembering that we need to be thinking about it, even if it's a family that does not on the surface seem to be at risk. There may be risk factors there that we have not uncovered. I think I'm going to go back to realistic expectations, and anything we can do to help families learn what realistic expectations are, I think can go a long way toward preventing abuse. And then, of course, the TEN-4 Bruising Rule.
You know, our mission is to empower families and prevent child abuse. So really, when we make any decision about programming or anything, we always discuss, does this empower a family? Because it's all we're just putting Band-Aids on after the fact. But if we can really intervene at that birth to 5, it just changes the outcome for everybody.
Everything, everybody, you know.
Yeah.
Everything, everybody, forever. That's not
Yep.
Yeah. I'll just pitch. I'm going to say real quick, I know that we're closing, but some exciting new research we're doing is in epigenetics. So we've been looking at how stress impacts your genes and how genes are actually turned on or off, and then how that builds the kind of brain that you're going to have, whether it's going to be a executive function brain or just a reactive brain. And it also builds your immunity, and it builds what your personality is going to be like in addition to what you already were born with. But it shapes you, your environment shapes what kind of person you're going to be and what kind of health you're going to be. And we our pilot study has already shown that if you have or if you're treated a very negative way, like the negative ways, like these attributions, negative attributions, or if you have physical injuries from abuse, even as an infant, genes that actually control what your health pattern is going to be like later in life is already malfunctioning, including your mental health, related to mental health, related to your heart disease, and related to immunity function. And I'm super excited about that because it's reversible. And I'm super excited about it because what's really interesting is that we just looked to see if your TEN-4 was positive. Having a TEN-4 positive predicted your genes were actually going to be malaligned for future health problems. But what was exciting is that with the things that this group is talking about with the hands and with the little people, what was the name of it? I liked the name of it. Little people parenting or something like that.
Little learners.
Little learners, yeah. That it actually looks like it can reverse that gene back to being a healthy state, so you actually give that child's potential back. So it's just so exciting, I can't even stand it. You know, this is the most exciting work I've ever been involved in, and I can't wait we're working to publish that right now. Melissa knows I'm the slowest publisher in the world, but it's going to happen. And so I'm very excited because what you're doing actually changes the whole entire trajectory of these children. But we even found that the parents' health actually improved when we actually helped them understand and engage with their children differently.
Well, thank you so much for that. That's so exciting. And I feel like Shannon could probably jump back in and talk about this for like another hour because it's so great. But just to wrap all of us up, thank you so much, Dr. Mary Clyde Pierce, to Dr. Melissa Currie, Pam Darnall, and Lynn Hulsey, all of you for joining us today, for sharing your expertise, and for all that you all are doing and all that you have done for kids and families over the years. So at the Face It movement, one of the things that we always say is that keeping kids safe is up to all of us. And today you all shared some really practical information around recognizing and responding to potential abuse, the importance of having realistic expectations for your children, normalizing how difficult and stressful parenting is and even crying. And then also talking about like the preventative services that are available, like hands. Those are all things that people can share or that they can use to do their part to keep kids safe, especially in situations like we were talking about today, where sometimes the kids are just too young or they're too afraid to articulate what's happening. And I also appreciate hearing about the ways that racism and bias and privilege show up in your workplaces and with the communities that you serve, and how you all are working to combat that both in practice and even in the language and the messaging that you guys are using, and really how you're promoting anti-racism and expansion instead of just inclusion. So thank you all so much again for joining us. Next week, we are going to have another conversation that that ties in pretty well with this. It'll be a discussion around a proven primary prevention strategy on how to keep young kids safe. So we'll be joined by Representative Josie Raymond and Representative Jason Nemus to discuss paid family leave. And that'll include the benefits of the policy for kids, their caregivers, and the workplace, along with the upcoming legislation in the 2021 session. So we will send you all an RSVP link to that forum along with the recording of today's forum. We'll also share some TEN-4 resources. We'll share the link to register for one of the 6 free pediatric abusive head trauma trainings that we'll be hosting starting September 30th and ending on October 8th in a follow-up email as well. So thank you all again for joining and have a great rest of your day.